Hello, welcome to Complete Anatomy. My name is Dr. Alan Detton, and in this lecture I will be going over surface anatomy. By the end of this lecture, you will be able to identify the surface anatomy landmarks on the anterior and posterior aspects of the upper limb. Identify the surface anatomy landmarks on the anterior and posterior aspects of the lower limb. Identify the surface anatomy landmarks of the back, thorax, abdomen, pelvis, head, and neck. And lastly, describe clinical applications for the surface anatomy of each body region. One of the areas where surface anatomy can be quite important is here in the thoracic region. The thorax is going to house and protect the vital organs of the heart and lungs. So it's really important to have a proper understanding of how those structures would present along the surface of the body. A good place to begin the exploration of the thorax is in the midline at a depression known as the jugular notch at the inferior aspect of the neck, or the base of the neck. Now, the jugular notch is going to lie between the sternal ends of the clavicle to either side. Let's begin first by moving laterally along the clavicle, which can readily be felt in most individuals because there's very little superficial fat lying superficial to the clavicle. As you start to move laterally, you're going to reach the lateral aspect, which is the acromial end of the clavicle, which meets up with the acromion process of the scapula here at the acromioclavicular joint near the shoulder. So the clavicle can be a useful landmark for structures within the upper limb as well as within the thorax. If we were to look at a midclavicular line, this is also going to help with orientation down inferiorly in the abdominal cavity. Another useful landmark that can be readily seen is the nipple. And the nipple is going to be at the T4, or our fourth thoracic dermatome region. And that might vary somewhat in individuals, but it's a great visual cue for about the fourth intercostal space. If we move laterally from the nipple, we can see the anterior axillary line or fold here in this thin individual, which is about the inferior aspect of the pectoralis major muscle. Now, if there's an anterior axillary fold, there's going to be a posterior axillary fold. And between those two is a depression in the armpit known as the axillary fossa. And this is a great landmark for physicians to use an approximation of the mid-axillary line for orientation if they need to place a chest tube into those intercostal spaces to drain fluid within the thoracic cavity. And again, if the nipple is approximately at the fourth ribs level or its intercostal space just below it, then a physician could count 2 more levels below to reach the fifth and the sixth intercostal space, which are common placements for a chest tube. Now, other landmarks are going to lie closer towards the midline. So again, beginning at the clavicle and moving medially, we're going to be able to reach the jugular notch. The jugular notch lies in the midline of the body, which is also referred to as the mid-sternal line, which would divide the sternum equally into right and left halves. Now, inferior to the jugular notch, we're going to feel a transition between the manubrium and the body of the sternum, which is the sternal angle, approximately, in most individuals, at the level of the second costal cartilage. Now, this is another landmark that can be very useful and easily felt to start to count where the ribs are and where the intercostal spaces are. So the sternal angle is far more consistent than the nipple, which can change orientation with the amount of fat in the region. If we move inferiorly from the body of the sternum, we can reach the xiphoid process, which is a small arrow-shaped piece of bone on the inferior extent of the sternum. And the xiphoid process is a good landmark for the inferior aspect of the heart and the superior aspect of the liver, neither of which want to be punctured during chest compressions. So if you were to feel for the xiphoid process, place 2 finger lengths above it, and then perform chest compressions on the body of the sternum, you're less likely to damage or injure the individual you're trying to save. Now, if we move laterally from the xiphoid process, we can move along the costal cartilages and feel the costal margin, which will then help us differentiate the contents within the thoracic from the abdominal cavity. The abdominal cavity can be an interesting area for palpation because it does not have as easily felt of skeletal landmarks like the other regions of the body that we've looked at. Here, we're going to have an anterior wall formed by muscles and soft tissue structures. So we need to rely a lot on visual cues from the thoracic region or inferiorly along the pelvic region to help with orientation of where things would lie in the abdominal cavity. To further complicate things, not everybody is as thin as our model represented here. So there can be a large layer of subcutaneous tissue or fat that is going to accumulate in the abdominal region, often complicating palpation. So let's begin by looking at a couple landmarks that are there for everybody, beginning with the belly button, or the umbilicus, sometimes called the umbilicus. Now, the umbilicus or the umbilicus is going to lie in the midline of the body and can be a great reference tool just for a simple subdivision, and it will lie along the anterior median, otherwise known as the mid-sternal line. So a mid-sagittal cut of the body should bisect the umbilicus. Another point of visual landmarks is going to be halfway along the clavicle, which is the mid-clavicular line. And typically, the mid-clavicular line is going to be along the lateral aspect of the six-pack muscles, our rectus abdominis. And the rectus abdominis will be subdivided by small lines known as tendinous intersections. So in a thin individual, if they flex, you'll be able to actually identify both the midline of the body, the tendinous intersections, and the muscular components of this muscle. And that midclavicular line can help you with orientation of structures internally inside the abdominal cavity when it's subdivided into 9 abdominal regions. Now, if we were to continue inferior to the umbilicus, we will see the midline structure of the pubic symphysis, where the right and left sides of the pubic bones come together. And this can also typically be felt in individuals. And there may be varying amounts of fat lying superficial to it, and it may not be the most comfortable for somebody to have palpated. Moving laterally from the pubic symphysis and the pubic tubercles to either side would be the attachment of the inguinal ligament, which separates the abdominal cavity from the thigh. But at the lateral extent of the inguinal ligament, we can palpate the anterior superior iliac spine, part of our hip bone or the ilium. Moving from the ASIS superiorly and laterally, we can feel along our hip bone, which is the iliac crest. And the iliac crest is going to meet up with the mid-axillary line, typically towards the most superior extent of this bone. Now, another couple of landmarks that we saw within the thoracic region can also help us with orientation here in the abdominal cavity. Again, the inferior extent of the sternum at the xiphoid process and the costal margin, which will descend as it moves laterally between the thoracic and abdominal cavities. The back may not be your first area that you think of when you think of clinical procedures or surface palpation to help you identify different landmarks within the body. However, there are a couple of very key procedures and things that are done by a physician that will be performed here in this area of the body. Let's begin by looking at the posterior median or mid-vertebral line. And as its name implies, this is going to lie in the midline of the vertebral column. The bony landmarks that can be felt along the posterior aspect of the back are the spinous processes. And these will be the posteriorly directed pieces of bone that are going to lie superficially. And in a very thin individual, you can actually see a collection of small bumps along the midline. Now, in everybody, you can palpate the vertebra prominence, or I should say in majority of individuals. Now, the vertebra prominence is the spinous process of the 7th cervical vertebra, the most inferior of these bones. So it can be a great landmark that can be used to palpate both cervical or thoracic levels. If we continue to move inferiorly along the median or mid-vertebral line, we can see it's going to create a groove between two large groups of muscles to either side. These groups are known as the erector spinae, and they're important postural muscles in our lower back that are going to extend up through the thoracic region as well. Now, the erector spinae are going to attach inferiorly towards the hip bone, otherwise known as our ilium. And the ilium is going to terminate posteriorly at the posterior superior iliac spine. This is also going to help you identify where we're starting to meet the sacrum, as well as the 4th and the 5th spinous processes of our lumbar vertebrae, which can be a great visual landmark for a physician to be able to see this and then feel it if they're going to be counting up to do a lumbar puncture or an epidural. If they continue to move laterally from the posterior superior iliac spine, or the PSIS, they're going to feel along the iliac crest. And we can see that the iliac crest is actually going to be higher than what we think of as our gluteal region. So if you're looking at the folds within the buttocks, you're going to be a little bit too low if you're looking for where the approximate midpoint of a safe hip injection would be. You want to avoid the large sciatic nerve in that region. Another area that can be useful for a physician is they're going to be listening or auscultating to the lungs posteriorly in a small window between muscles known as the triangle of auscultation. And this is going to be near a few large muscles in the area that will create the borders that are difficult to see. However, we can usually feel or palpate the inferior angle of the scapula, which will lie just lateral to this small triangle. If a patient were to lean forward, they would be able to have this triangular window enlarged, which will ease the ability to listen to the health of the lungs in that individual. Now, moving from the inferior angle superiorly, a physician is going to be able to feel along the medial aspect of the scapula. A more prominent landmark to feel in the scapula is the spine of the scapula. And if you reach your right hand up over your left shoulder and use your fingers, you can feel that spine moving medially, which can also help you find that medial or vertebral border of the scapula. So the scapula is going to have a medial aspect and a lateral aspect that are going to come together at that inferior angle, which again can usually be felt in some individuals. In a clinical scenario, a physician is often going to rely on visual cues or on things that they can easily feel. So this is where the surface anatomy is going to become quite important and relevant to the physician. So they want to be able to either see things or feel them just under the skin. Now, many of these structures are going to be felt under the skin or palpated, while others can simply be viewed. Let's begin looking at the surface landmarks anteriorly in the upper limb with the clavicle. Recall that the clavicle was one of the two bones involved with the shoulder girdle, and it is going to be attaching from the manubrium medially and laterally out towards our scapula. The point of attachment of the clavicle to the scapula is at the acromioclavicular joint. So a physician would be able to palpate along the superior border of the clavicle until it meets up with the acromion process of the scapula, and then palpate the acromioclavicular joint. Typically, a physician could palpate through the large deltoid muscle and feel the greater tubercle of the humerus, located more laterally, a small depression potentially for the intertubercular groove, and a more anteriorly located lesser tubercle of the humerus. Recall that the tendon of the long head of the biceps is going to pass in that intertubercular groove between the lesser tubercle and greater tubercle of the humerus. So this can be a useful area for the physician to be able to palpate regionally and feel those bony landmarks deep to the thick muscle of the deltoid. As we move inferiorly towards the elbow, a physician is really going to be able to palpate quite easily the two epicondyles of the humerus, the lateral epicondyle on the lateral aspect of the elbow and the medial epicondyle on the medial aspect. Recall that the ulnar nerve passed just posterior to the medial epicondyle, and often if a patient hits the medial aspect, they're going to feel a tingling in their palm related to the funny bone, which is the ulnar nerve. So being able to palpate the medial aspect and see the origin of the forearm flexors and the lateral aspect for the forearm extensors can be quite beneficial for a physician. Moving towards the wrist, we're able to almost always palpate the two styloid processes. The styloid process of the radius is going to be positioned on the lateral aspect of the distal radius, and that's going to limit the ability to abduct or laterally deviate our wrist. On the medial aspect of the palm of the hand, we're going to be able to palpate two structures, the pisiform and the hook of the hamate. So two of the carpal bones are readily palpated near the base of the hypothenar eminence within the palm of our hand. Typically, we're also able to palpate the heads of the different metacarpals on the palmar aspect of our hand. And you can also use the proximal and distal ends of the phalanges to palpate through the different joints of the hand. So surface landmarks and surface anatomy are going to be a useful tool for the physician to help diagnose underlying clinical issues. Some of the structures that we were able to palpate and or see along the anterior aspect of the upper limb are also going to be identifiable from a posterior perspective. But we're going to now add to the list a few more structures. The first of these is going to be related to the scapula. The medial border of the scapula can be palpated along the medial edge here of the posterior aspect of the shoulder. Now, the patient might need to roll their shoulder or abduct it slightly or protract it or retract it in order to facilitate a physician being able to properly palpate from the inferior extent of the scapula up along the full length of that medial border. It's quite easy, however, to palpate the spine of the scapula, and you can even do this on yourself by placing the contralateral hand up over the shoulder and walking along the length of the spine of the scapula, which could help you identify the supraspinous and infraspinous fossas. If you continued to palpate laterally along the spine of the scapula, you would reach the acromion process of the scapula, which would then wrap around to form the acromioclavicular joint with the lateral end of the clavicle. At the elbow, we're going to be able to palpate the same two epicondyles of the humerus from a posterior perspective. We're going to be able to feel the medial epicondyle and lateral epicondyles of the humerus. Additionally, you're going to be able to palpate between the two epicondyles the olecranon process of the ulna. Now, the olecranon process of the ulna if you flex and extend, is going to be able to still be felt in any position of flexion. Palpating down through the forearm, you should be able to feel the posterior border of the ulna, which is going to be quite superficial along the posterior aspect of our forearm. Continuing to feel down the posterior border of the ulna, you will end at the styloid process of the ulna, which is going to be directed more posteriorly than the styloid process of the radius, which will be more laterally located. So remember that the styloid process of the radius limited lateral deviation of our wrist, while the styloid process of the ulna is going to limit extension of the wrist. Typically, in the back of the wrist, you can palpate the capitate, which is going to be the most pronounced carpal bone that you will feel, especially in a flexed wrist along the midline. The metacarpal bones can similarly still be palpated on the dorsal aspect, and actually the heads of the metacarpals are going to be relatively easy to palpate in anybody as they flex or make a fist, as are the different interphalangeal joints and the phalanges involved in the fingers. In order to perform a productive or effective evaluation of a patient, the physician will often need to rely on visual cues or things that they can feel underneath the skin within a patient. Therefore, a proper understanding of the structures that are in the surface of the skin, that we refer to as surface anatomy, is an essential foundational set of knowledge that a physician must rely on. Let's begin with looking at some of the surface anatomy that can be palpated or felt within the inguinal region. First, a physician can almost always palpate or feel the iliac crest, the large prominence of bone on the lateral aspect of our hip that we can better see on the side of the body here that does not have the skin. If the physician were to follow the iliac crest anteriorly, they will arise at the point known as the anterior superior iliac spine, or the ASIS for short. This is going to be the lateral attachment of the inguinal ligament, which is going to pass inferomedially along the crease between the abdomen and the thigh, to the point where it attaches medially at the pubic tubercle. Typically, in most patients, the pubic tubercle and the ASIS can be readily palpated. In a very thin individual, a physician might even be able to palpate the pubic symphysis in the midline. On the thigh, we're going to be able to palpate certain structures in thinner individuals more readily than larger individuals, such as the greater trochanter, the large prominence that is for gluteal muscle attachment on the lateral aspect of the hip. At the knee, a physician can palpate the distal aspect of the femur, with the lateral epicondyle and medial epicondyle of the femur readily palpated on the lateral aspect and medial aspects of the knee, to either side of the centrally located patella, which is perhaps the most readily identifiable surface anatomy within the body. Inferior to the patella to either side, a physician can palpate both the lateral and medial condyles of the tibia, just distal to where the patella is going to slide over the proximal end of the tibia. Near this location, a physician can also palpate on the lateral aspect of the knee the head of the fibula, which is going to be an attachment site for the fibularis longus and brevis, just inferior to the knee joint. They can also palpate Gerdy's tubercle, typically along the lateral aspect of the knee as well as the tibial tuberosity. The tibial tuberosity is going to be the distal attachment of the patellar tendon or ligament that is going to attach from the patella down to the tibia. Inferiorly, at the ankle, along the lateral aspect of the ankle, a physician can easily palpate the lateral malleolus, which is the distal end of the fibula, as well as the medial malleolus, which is the distal end of the tibia. Typically, the tibial crest or the anterior aspect of our shin can readily be palpated, which will then lead inferiorly to the medial malleolus. Lastly, within the foot, a physician can palpate the different metatarsal bones that are going to be within the central aspect of our foot, as well as the different phalanges in the toes. Some of the structures that were able to be palpated or felt along the anterior aspect of the lower limb can also be palpated along the posterior aspect, as these structures are going to either be along the lateral or medial aspects of the limb. Let's begin looking at some of the structures that can be palpated or felt within the skin of the lower limb posteriorly near the gluteal region, beginning with the iliac crest and the posterior superior iliac spine. As we can see, the iliac crest on the left side here without skin is going to terminate posteriorly at the posterior superior iliac spine, often abbreviated simply as PSIS, and this can be an excellent landmark within the gluteal region. They can also palpate the gluteal fold, which is going to be the fat-filled crease along the inferior aspect of the buttock. On the lateral aspect of the hip, the greater trochanter is a good landmark that will help a physician identify the approximate path from the PSIS to the greater trochanter for the location of the piriformis, which can help them identify the approximate path of the sciatic nerve. At the knee, a physician will be able to palpate both the lateral epicondyle of the femur and the medial epicondyle of the femur from both a posterior and anterior perspective. Along the lateral aspect of the leg, just inferior to the knee, they can also palpate the head of the fibula, posteriorly and slightly laterally here at the back of the knee. Near the ankle, a physician will be able to palpate both the medial and lateral malleoli, which are going to be the inferior or distal extents of the tibia along the medial aspect and the fibula along the lateral aspect. Additionally, at the heel, they will be able to palpate or feel the calcaneal tuberosity, which is the inferior or distal attachment of the calcaneal tendon, which is the large tendon attachment of the gastrocnemius and the soleus. The anatomy of the face and the head can readily be felt or palpated in the majority of individuals due to the thin layer of subcutaneous or connective tissue. Now, as a landmark, let's begin along the jawline, otherwise known as the body of the mandible. In the body of the mandible is this horizontally oriented portion of the bone, where if you were tired and rested your chin on your hand, you would likely be resting it on the body of the mandible. The body is going to change directions at the ramus or to the ramus at the angle of the mandible. So if you were to move posteriorly along the body, it's going to change directions and the bone will start to ascend vertically. And this is the angle of the mandible. Now the ramus is going to continue superiorly, and if you were to continue to palpate up the side of the face, you would actually start to reach towards the zygomatic arch, which is part of the zygomatic bone or your cheekbone. Now, moving posteriorly on either side from the mandible, superiorly, you start to get after the angle towards the ear. Now, the anatomy of the ear is going to vary in some individuals where they may have an attached earlobe or not, and that portion of the ear is known as the lobule. It's a fleshy, large portion inferiorly that is often pierced. The large outer circumference of the ear is known as the helix. We also have a small prominence that is going to project from the anterior aspect moving posteriorly, covering up over the opening, the external acoustic meatus. And this small piece of tissue is known as the tragus. Posterior to the ear, we're also going to have a large bump, which is the mastoid process. And this is going to be one of the attachment sites of the muscle in our neck, the sternocleidomastoid. Again, readily felt posterior to the ear, and this is part of the temporal bone. Moving towards the back of the head, there's often a bump that can be felt right in the midline towards the base of your skull. This is the external occipital protuberance, and it's part of the occipital bone. So these are landmarks that can easily be felt in an individual. We're also going to have some landmarks that are simply seen visually, but could also be touched or felt, including around the circumference of the oral cavity, where we can see a change in color from the fleshy pink type of appearance of our lips towards the rest of our skin of our face. And this is known as the vermilion border, and it may be more or less pronounced in different individuals. Superiorly to the upper lip, we're going to have a small depression or indentation in line with the nose, and this is the philtrum. The philtrum is going to lie in the midline to either side of the openings to our nasal cavity, the external nares, otherwise known as the nostrils. Moving superiorly along the bridge of our nose, we can feel the nasal bones. From here, if a physician were to palpate laterally, they'd be moving along a bony prominence known as the superciliary arch, or the brow. And in many individuals, there's a small indentation known as the supraorbital notch, which is where we're going to have neurovascular structures from the orbit reach the forehead. The surface anatomy of the neck is fairly straightforward in that most of the structures that can easily be palpated or felt lie approximately in the midline. One exception is a large muscle that cuts diagonally across the neck, the sternocleidomastoid muscle. And this is a great landmark muscle for physicians who may be trying to feel enlarged lymph nodes along this diagonally oriented muscle, or looking potentially for a pulse in the carotid vessels just deep to this muscle. Now, the sternocleidomastoid is named due to its sites of muscular attachment. Inferiorly, it is going to attach to both the sternum and the clavicle, particularly the sternal end of the clavicle, which is towards the midline of the body. Between the two sternal ends, there's a small depression known as the jugular notch, which is just superior to the manubrium of the sternum. So if we begin by palpating the bony skeletal landmarks of the manubrium and the medial or sternal end of the clavicle, you can start to ascend diagonally up through the neck along the sternocleidomastoid muscle. Now, superiorly, the other portion of this muscle gets its name due to the large bony prominence posterior to our ear of the temporal bone, known as the mastoid process. So sternocleido gets its name from sternum and clavicle, and mastoid from the mastoid process. Along the midline of the neck itself, we're now going to use a landmark that is more prominent in males than females, and this is the laryngeal prominence, otherwise known as the Adam's apple. And we can more readily see this if I fade a portion of the skin on the right side of the neck. Now here we can see the extension of the cartilaginous tissue right in the midline of the neck. This is the thyroid cartilage. And with puberty, a secondary sex characteristic of males is that this starts to become more elongated and pronounced and project more anteriorly, which will help to deepen the voice and the vocal cords get longer. Now, the laryngeal prominence is a midline structure that can be used as a landmark. If we move superiorly towards the angle between the jaw and the neck, you can often palpate the mobile hyoid bone just deep to the skin. Inferior to the laryngeal prominence, we can palpate the next piece of cartilage, which is the cricoid cartilage. And between the cricoid, the more inferior piece of cartilage, and the thyroid cartilage, we have the cricothyroid ligament. And this is an excellent point for an emergency individual responder to be able to do a tracheotomy in an emergency situation where they may need to open up the airway. And this is a safe place to perform this procedure, where they will be able to palpate with their thumb or a finger the laryngeal prominence, move inferiorly, and fill a small gap between the cricoid and thyroid cartilages. And here is where they would insert a knife or a small scalpel to be able to open up the airway to ensure that the individual can breathe and get air into their lungs.
In this lecture, we will review some basic surface anatomy features that are easily palpable on yourself or on a patient. Let's begin in the midline at the pubic symphysis. The pubic symphysis is in the exact midline of the pelvis, and just lateral to it is a bony prominence known as the pubic tubercle. The pubic tubercle is important for the reason that the inguinal ligament attaches to it in the midline. If we palpate and follow the inguinal ligament laterally and superiorly, you can feel the prominent bony feature at the front of your hips known as the ASIS, or the anterior superior iliac spine. So between the ASIS and the pubic tubercle runs the inguinal ligament. Now if we move down in towards the external genitalia on the penis, it is subdivided into the body or shaft of the penis, and if the individual is uncircumcised, they will have a longer and more noticeable foreskin, and on the distal end of the penis is the external urethral orifice. Posterior to the penis is the scrotum for palpations to check for things like testicular cancer.